So thanks, Adam and Jared, for organizing the symposium this morning. And thank you for inviting me to speak this morning at this first masterclass for the Department of Internal Medicine. I think it's a wonderful initiative that you've started. So obesity is really becoming a major problem worldwide, and particularly is now becoming quite a big problem in many, many developing nations. And as we've become experienced physicians, we have actually come to realize that obesity is truly a multifactorial disease and has highly complex pathogenetic mechanisms at play, which Farzana highlighted early on, which includes biological, psychosocial, socioeconomic, genetic, environmental factors. And it is quite important to realize that there's a marked heterogeneity in the pathways and mechanisms by which leads to adverse health outcomes. And as Farzana even alluded to in her first presentation, there's a marked heterogeneity in response to treatment with the variety of options that we have at present. So, many of you have shown some of the sort of prevalence of obesity in Africa and South Africa and worldwide. And this is just a slide, it's a 2016 slide, and showing that we have quite a national problem with a fairly high incidence of obesity in this country. I was struck by it when we did a survey of rheumatic heart disease prevalence in Alexandra Township a few years ago. And already then we saw what we see on this graph, that there were a number of young girls, school-going girls, who in fact fell into the obese or moderately obese range already at that stage. So I know there was talk about what to do in future, but I think if we're going to address this problem, this certainly needs to be addressed at a young age. So the main topic today I'm going to discuss is obesity and cardiovascular risk. And I'm going to start off this in highlighting the link between obesity and cardiovascular disease. And I show the slide for a number of reasons. Firstly, it is a longitudinal study, and it involved participants aged 6 to 49 years, and about 2,600 patients were involved and who were followed up for 31 years. And during that time, they had repeated measurements, not only for height and weight, but a variety of other tests which assess their cardiometabolic health. And so secondly, it also highlights their BMI trajectories over time and their associated cardiovascular risk. And so they divided these groups into 6 classes. In the majority, my apologies, they started off fairly normal weight, and then you can see the groups that stratified into rapidly obese and staying in that group, some starting low and then going very rapidly into the high group. And what it was at the end of the study was the assessment of the cardiometabolic risk profiles in this group. And what it shows here, so I've just shown 3 columns, and there were other dyslipidemic risk factors that were monitored and measured, but I've not shown that on the slide. You can see the highest risk was, you can see the risk ratios are almost treble for hypertension, carotid intermediate thickness, and diabetes in the group that started off being obese and then rapidly progressed over time over 31 years. The next group was, in fact, that started normal, and then you can see they rapidly became into the obese range, and they had also significantly elevated risk ratios. Compared to the normal group was then regarded as the reference group. And if you look in the pink sort of column here, everyone who remained obese over this duration had a significant risk ratio increase over that period. And even if you fell into the mildly overweight group, there was some increase in risk. Now, what this lower group that in fact fell into the overweight group and then came down to normality, their hypertension risk certainly fell, but there was still an increased risk with regards to carotid intermediate thickness as well as diabetes. So it suggests that even any length of duration within the overweight or obese group does provide, or in fact confer, an added risk. Okay, so this slide is shown in a slightly different format to the previous graphs, and it's the predicted probability of having a cumulative cardiovascular disease risk load. And I've shown that in fact, if you fall into the stable normal as compared to the persistent increasing overweight, sort of this one here on the right-hand side, you can see your probability is almost 50% higher of developing quite significant cardiovascular risk profile. And in fact, it's almost a straight line upwards as your length of time being obese and remaining obese persists over time. So it's not only being obese at a particular time point, it is the length of obesity or being overweight that is also important in accumulating cardiovascular risk. So I'm just going to briefly touch on visceral adiposity and cardiovascular risk. And so this study was done many years ago. It was the pathobiological determinants of atherosclerosis in youth. And what they did was young people who died in motor vehicle accidents, etc., then had postmortems, and they sectioned their aortas and coronary arteries and looked at atherosclerosis, and then tried to go back and look at their histories. And in this group, in fact, besides a whole host of other factors, only in those with a thick abdominal paniculitis was associated with increased atherosclerotic lesions in men. And remember, these men were in their late 20s or early 30s. So that time already suggested that abdominal or visceral adiposity had a much more convincing cardiovascular risk than other forms of adiposity. There was another study done in the early 2013, and they looked at MRI studies and basically compared visceral adiposity versus subcutaneous adiposity. And you can see, and what they did was divided into 3 tertiles of the accumulation of visceral adiposity into tertiles 1, 2, and 3. So as your visceral adiposity, which now we know as abdominal obesity and measured by waist circumference or waist hip circumference levels. So certainly with much higher tertiles, your cardiovascular risk almost triples or quadruples as compared to the lower tertiles. So visceral adiposity adds to cardiovascular risk significantly. So I'm going to dwell a few minutes on obesity and coronary artery disease, as this is highly prevalent. So there are several prospective epidemiological studies which demonstrate that obesity is associated with high risk of incident coronary artery disease. In a meta-analysis of over 300,000 adults, demonstrated that BMI in the overweight and obese ranges was associated with elevated CAD risk. The degree and duration, as I mentioned earlier on, obesity is measured by total cumulative exposure to excess overall and abdominal obesity, and expressed as excess BMI years and waist circumference years, has shown to be a strong predictor of CAD events beyond BMI or waist circumference alone. So if we look at this, a meta-analysis of 21 studies, and this included about close to 2 million individuals, suggested that approximately half of the associations of overweight and obesity with CAD are explained by levels of blood pressure, cholesterol, and glucose. So where's the other half due to? Now, there may be in these analyses not proper accounting for confounding, etc. But there are interesting animal experimentations which show that there's an interesting study in rabbits which showed that an intramyocardial course of an LAD segment is normal compared to an epicardial portion of a vessel which is exposed to pericardial fat. And these rabbits were cholesterol-fed rabbits. And thus implicating that the pericardial fat implicated adipocytokines in modulating vessel biology and promoting atherosclerosis. So adiposity or obesity itself may be a risk factor for cardiovascular disease, other than all the other attendant risk factors that it promotes. So if we look at the pathophysiology, we know that the atherosclerotic process is initiated in childhood with the ingestion of cholesterol esters to form foam cells and their deposition in the vessel wall, resulting in thickening of the arterial intima. And as further accumulation leads to development of what initially starts as a fatty streak. So now obesity on the left panel accelerates all these atherosclerotic changes through several mechanisms, including one, causing insulin resistance, and two, inflammation. We know that atherosclerosis by itself is an inflammatory process. And then remember, all the secondary effects of obesity contribute to atherosclerosis. That's elevated blood pressure, dyslipidemia, and hyperglycemia. So what about the diagnosis of coronary artery disease in obesity? There's a whole host of tests that we utilize in practice to assess cardiovascular disease. And of course, the one that is cheapest and we use routinely is the ECG. But in obesity, it might not have the sensitivity and specificity as normal individuals. So often we see increased heart rates in patients who are obese. The QRS interval may be increased. The QTC interval may be also increased. And because of abdominal obesity and the diaphragms being pushed up, you often get a horizontal heart position. And this may result in false positive criteria for inferior myocardial infarction. And less clinically significant are all these other minor changes, like you may see increased PR interval, QRS voltages, etc. The other important one is you may see ST segment depression. This sometimes has been linked to hyperinsulinemia. And then sometimes we see left atrial abnormalities as well. So there's a host of ECG changes in obesity. What about the treadmill test, which we also use widely? The problem with obese patients, they're often not fit and they cannot do an adequate exercise test and they stop prematurely. So we do not get an adequate heart rate response. And so often the test is suboptimal in many patients. The cardiolite SPECT test is quite a good precision test. It's available widely. But again, it does have technical limitations because of body size. And sometimes the machine doesn't correctly attenuate because of the body size. Stress echo, although it's widely available, it's not performed widely in this country. But again, it's limited because of poor acoustic windows. Anyone who's tried to do an ultrasound in a very obese patient will realize that that can be a very, very difficult task. And then cardiac CT angiography is a useful tool in assessing coronary artery disease. Although it is highly sensitive and it's high negative predictive values in normal individuals, its image quality does degrade. And depending on the machinery, so you can get degradation related to background noise, etc. So again, a useful test, but does have limitations. What about coronary angiography? Now, all of us who've done coronary angiography has always found that vascular access in obese individuals is extremely problematical. And therefore, radial access is now the preferred choice in very obese individuals. But in very complex situations, we still need to have femoral access. So it does give added access problems. One of the things that we routinely see is suboptimal radiographic visualizations. So the machine has to put out more radiation to get an adequate picture. So there's more radiation exposure to patient as well as the staff. And there's a much higher likelihood of complications in patients who are obese and who undergo coronary angiography. Extreme weight, I remember at Charlotte many years ago, before the new cath lab, we were unable to do coronary angiography on patients who were greater than 120 kilograms. The table was just unable to, in fact, accommodate patients greater than that weight. So what about outcomes? If we look at this registry data of cath PCI registry, and it looked at about 83,000 patients with severe obesity and included patients with myocardial infarctions. And after a number of multivariable adjustments, you can see that obesity was independently associated with greater mortality. And the mortality was almost 20% higher than normal individuals, but it did have a lower bleeding rate. Also, it's important to note that obesity, although many of the antithrombotic drugs have weight-based dosing protocols, most of the studies, in fact, kind of did not include obese individuals in these studies. So actually, we do not know what is the adequate anticoagulant dose in many of these obese patients. This is another study, and it is a registry of both PCI, Blue Cross Blue Shield of Michigan, of both PCI and bypass surgery. And what it shows, sorry, this was only PCI registry, and shows that CIN stands for contrast-induced nephropathy. So if you compare the lean or the normal individuals, there was a substantially higher risk of contrast-induced nephropathy, again, because we need to use more contrast to get better imaging in these individuals. And so there was almost a twofold risk of having contrast-induced nephropathy in these obese individuals. So those, in fact, requiring dialysis, renal dialysis, again, in this submorbidly or morbidly obese individuals, the risk of being dialyzed after angiography was significantly increased if you developed contrast-induced nephropathy. Again, in this PCI registry, the death rate was higher as compared to lean individuals, and the vascular complications was much higher. So showing that just the diagnosis and treatment of these patients carries an adverse outcome in these patients. What about bypass surgery? This is an analysis of almost 865,000 patients who underwent both PCI and CABG. And that which shows that although there's an obesity paradox in those with low BMIs, and we've known that for females and males for a long time, but certainly as the BMI increases, the mortality, certainly both males and females, increases substantially. We've always known that females have a higher risk, both with PCI and coronary artery bypass grafting. The next big topic with obesity is heart failure. So we know that obesity is a major risk factor for hypertension, and it has potent effects on left ventricular systolic functions. So we look at the pathophysiology for this heart failure. Firstly, on the left side, we know that in obese patients, we get myocardial fat deposition together with insulin resistance. And this leads to altered metabolic profile with inflammation, insulins, and this promotes traditional risk factors of hypertension, type 2 diabetes. And we all know these are potent risk factors for developing heart failure. The myocardial fat deposition causes fibrosis. It causes abnormal conduction abnormalities, may cause increased heart rate. And the increased leptin and altered lipolysis also feeds into this axis of traditional cardiovascular risk factors, which then all impact onto heart failure. On the right-hand side, we see more the impact on the right heart failure. So we know there's altered peripheral vascular resistance together with insulin resistance in patients who are obese. And there's obviously the mechanical effects of abdominal fat on chest wall and raised intrathoracic pressure. We know the prevalence of obstructive sleep apnea, hyperventilation syndrome. This all leads to raised pulmonary artery pressure, pulmonary artery hypertension, and then eventually right heart failure. So that's the basic pathophysiology of heart failure in heart failure in obesity. So I've mentioned that obesity is a major risk factor for hypertension, and strong risk factors which all are strong risk factors for heart failure. And as I've mentioned again, obesity is a potent adverse effect on LV systolic function. And because of the infiltration of fat into the atrial wall, diastolic dysfunction as well. So multiple studies have shown that obesity is a major risk factor in the development of heart failure. And the Framingham Heart Study, looking at almost 6,000 patients, you can see heart failure increased by 5% for every unit of BMI increase. So as compared to normal individuals, as the BMI rose, the incidence of heart failure increased substantially. And this is for men. And it was similar for women. In fact, it was even higher, where the heart failure incidence rose by 7% for every unit of BMI increase. This I just included yesterday because it's a very, very recent publication. Obesity modifies the energetic phenotype of dilated cardiomyopathy, and published in the European Journal of Cardiology. And so what they did was they looked at patients, a small number of patients with normal weight cardiomyopathy and overweight cardiomyopathy. And what they found on MRI spectroscopy, that normal weight dilated cardiomyopathy is associated with reduced resting ATP delivery. And on the other hand, in obese dilated cardiomyopathy, the ATP demand through to site kinase is greater, suggesting a reduced energy efficiency and utilization. So this study, although small study, before that, the dietary weight loss was associated with a significant improvement in myocardial contractility as well as ATP delivery. So their final conclusion was they suggested that there was a distinct energetic pathways in obesity cardiomyopathy, which are both different from dilated cardiomyopathy in normal individuals, and this may be reversible from weight loss. So interesting new study. So what about obesity and heart failure preserved ejection fraction? And we know that heart failure preserved ejection fraction is quite common in patients who are obese individuals. And this study, published in the Journal of the American College of Cardiology, Heart Failure, in 2018, where the authors looked at physical activity and obesity and in patients with preserved ejection fraction. And in fact, the relationship was much more potent of obesity with heart failure preserved ejection fraction as compared to heart failure reduced ejection fraction, or the traditional idiopathic dilated cardiomyopathy. And one can see, although the risk ratio is increased as the body mass index increases for reduced ejection fraction, in those who were class 1 as far as preserved, and class 1 obesity and overweight, there was almost a 38 to 56% higher risk of heart failure preserved ejection factors. And this was independent of all the other cardiovascular risk factors. What about heart failure outcomes? Now, this is an interesting observation, that there appears to be an obesity paradox in heart failure. Data support that patients with overweight or class 1 obesity have better clinical outcomes than patients with normal weight and similar degrees of heart failure. And this is seen for reduced ejection fraction and preserved ejection fraction. However, the exact reasons why those who have overweight and mild obesity with less severe forms of heart failure are also protected is not quite clear, but this data seems to be shown in a number of studies. The other important concept I wanted to briefly address was obesity and arrhythmias. We know that obesity has direct myocardial effects. I've detailed these in the past, showing the hemodynamic changes of blood volume, cardiac output, and increased systemic vascular resistance. We know the raised blood pressure through activation of the renin and angiotensin system, and the myocardial fat accumulation and subsequent fibrosis. And then the secondary myocardial effects of hypertension, coronary artery disease, and pulmonary artery hypertension. So these can all promote arrhythmias. There's two arrhythmias that are important in obesity. One is sudden cardiac death, and the second is atrial fibrillation. So we know in obese individuals, there's QRS fragmentation as well as fibrosis. This may lead to, through ion channel remodeling, ventricular tachycardia, and sudden death. And in fact, in the publication in 2018, for every 5-unit increase in BMI confers a 16% higher risk of sudden cardiac death. In fact, obesity is the most common non-ischemic cause of sudden cardiac death. Abdominal obesity may also be a marker of sudden cardiac death. One thing we've learned over the last 5 to 10 years is the atrial fibrillation and obesity connection. We know there's significant atrial modeling, and this sets as a pro-arrhythmic substrate as a consequence atrial fibrillation. And if we look at some of the data, it may account for 20% of all cases of AF. And again, for every 5-unit in BMI confers a 29% higher risk of incident AF. And every 5-unit increase in BMI confers a 10% higher risk of postoperative atrial fibrillation. So the link between AF and obesity is quite strong. Now, this is the one area on management of obesity which has a significant impact. The study done in Australia, published in 2015, shows that with weight management, and these patients underwent aggressive weight management programs, and in fact, those who lost the greatest, more than 10%, had the best outcomes over 1,500 days, as compared to those who only lost 3 to 9% or who lost less than 3 or gained. So there was a significant improvement, and this is AF-free survival without the use of control So almost 50% were free of AF when they lost weight significantly. So weight loss in atrial fibrillation is quite an important strategy. So in summary, I'm going to end to say, with regards to cardiovascular disease, firstly, it's the presence. Obesity is clearly associated with heightened cardiovascular risk. And certainly duration is important. So the length of time being obese is important in conferring cardiovascular risk. And location, where fat is present, is important in conferring cardiovascular risk. The more visceral fat or abdominal obesity certainly carries a much higher risk as compared to elsewhere. I know Fazana and Sandeep touched on this, but we need to address this as a national goal. And if we are going to address this, we need to start early at the school level. Thank you very much.